Hi, my name is Ashul Govill. I'm a practicing cardiologist, also Chief Medical Officer at Story Health. We're a health technology and services company. We provide services for health systems to help them identify patients with gaps in their cardiovascular care and also help fill those gaps with interacting with the patient at home and providing solutions to make sure they get to goal. I'll be talking to you today a little bit about some of the things we've seen today. How do we use these tools, these platforms to really build the cardiology clinic of the future, or sort of a digital hybrid cardiology clinic? And I'll talk a little bit about Story Health along the way. So first, let's talk about the problem. What is the problem with cardiovascular care as we deliver it today? What's the care model look like? So the current model of cardiovascular care has a few issues. One of the issues is it just doesn't scale. Right? We know there's a shortage of specialists in this country, shortage of 13,000 specialists to be specific, and a lot of those are in places where we need cardiovascular care the most. Furthermore, even of the cardiovascular providers that we do have, and the doctors that we do have, a lot of their time, almost half of their time, if you look at studies, is spent on low-value work. They're not really providing all the care that they really could be. So even the time that they do spend is not efficient. And then lastly, of course, on the patient side is because there's no access to care, because there aren't enough providers, there's huge wait times. I think we saw before 45-day wait time to see a cardiologist sometimes. And oftentimes there's switching providers, there's a lot of discontinuity in the care they receive, which often results in big patient gaps. So all of this kind of really results in missed opportunities to treat these patients, provide medical interventions at the appropriate time for them, and of course, leading to significant gaps in care. These are some of those gaps in care that we see. So on the medical treatment side, we've heard a lot today about Pavilion-directed medical therapy and heart failure. 90% is probably generous. It's probably 99% of patients in this country with heart failure are not on the right medications. And hypertension, we obviously have problem with just diagnosing hypertension. Half of hypertension is not even diagnosed, but even when they're diagnosed, half of those patients are not controlled. On the procedural side, again, in heart failure, 95% of patients in this country who are eligible for LVAD or heart transplant don't actually receive that therapy, don't get referred on time. And in arrhythmia, with our EP folks, ablation often either doesn't happen or happens too late, and it reduces the chance of success with those procedures. So we're not reaching these patients at the right time. So why is it that we have these gaps? Why is it that world-class cardiology treatment is so difficult for all of us to achieve? There's several reasons. I can't go through all of them, but these are three I'll highlight here. One, I talked about already, referrals happen oftentimes too late, if at all. We're relying on someone to push the patients to us as specialists, rather than identifying who they are and pulling them in at the right time. Scarce clinician time. When almost half of our time is spent on low-value work, how are we really supposed to provide the care that we need for these patients? And of course, we talked about the access issue. When patients face those barriers to access, then they're just going to give up, and they're actually lost to the system, lost to follow-up. We've all tried several things. Many health systems across the country have tried several sort of things to build scalable models to address this issue. What are some of those things? One is care navigators. Care navigators help guide the patients to the right solutions, make sure that they're getting through the system. It can be often difficult to navigate the healthcare system. But these are resource-intensive solutions. Most of these care navigators can only handle a few patients at a time, as few as 20 or 30 per care navigator. It's just not something that's scalable in and of itself. So what's the other thing we've tried? We've tried more staffing. How do we get more MDs, more APs, more NPs, nurses? How do we increase the staffing to deal with this issue? But again, not economically viable, not scalable. And these days, with the Great Resignation, we can't even find these providers if we wanted to. So it's even a more of a pressing issue now post-pandemic than it has been ever before. And of course, the last thing we've tried is clinical education. Let's educate the clinicians, make sure they know what to do, and if they know what to do, they'll do it. But I don't think that's the problem. Most of the clinicians already know what to do. They already want to do the right thing. They're just not providing the structure and the right tools to actually provide that care for their patients. We've gotten a little fancier with this recently. We've tried things like EHR prompts. We've tried things like clinical decision support tools. Again, not something that actually is making a huge impact on moving that needle. And the clinical inertia continues in the wrong direction. So what is the current care model? For those of you who are clinicians, this may look familiar. This is maybe your current clinic day. Maybe your day starts in the morning, early morning, you get into the cath lab, you're doing a procedure, but it's running a little bit long, so you're late to see that first patient. You're already starting the day behind, and this is a real problem because you only have 15 minutes to see each patient. You rush in to see that first patient, and you had seen him a couple of months ago. This time you were planning on treating some medications, but guess what? They didn't get their labs done. You have no idea what their creatinine is. You can't make that medication change. Oh well, you just send them out with a reminder to get the labs done and see them again in 3 months. Next patient comes in, you had prescribed a new medication last time you saw them. But guess what? They never picked it up because they went to the pharmacy and there was a huge copay for that medication. Well, 3 months without the medication, but they have heart failure. They could have been readmitted. They probably will be next time. Oh well, go pick it up. We'll figure out some coupon programs for you or something. We'll figure it out. But I only have 15 minutes, so I can't deal with it right now. Next patient comes in, finally something that you can actually help with. They come with their family member, and appropriately, the family member is very concerned and wants to have a long discussion about goals of care. But wait, you only have 15 minutes. How are you going to do that? It runs over, and now you're running even more late. Luckily though, your next patient doesn't show up. Great, I'm back on time. But wait, what happened to this patient? Where did they go? What happened? Are they okay? You have no clue, because you have no insight into what's going on outside of the clinic. Finally, get a patient you can do something for, an actual physical exam. They come in short of breath, you listen to them with a stethoscope, diagnose aortic stenosis. First patient, it takes 5 patients to get there, but the first patient you actually do something for, and you send them over to the right treatment plan. But your day kind of continues like this, on and on and on. You run late into lunch, and so you have to grab pizza from the nursing station while you sit and make phone calls and do some charting. Goes into the afternoon, day's over, you're exhausted, you still have 2 more hours of charting, and guess what? You feel like, how much have I really helped patients today? Right? This is kind of the average clinic day today. We need to think about how to change this whole model. And what does this clinic day result in? It results in very episodic care for our patients. Let's take a patient with heart failure. Day 0, you see this patient, they're doing well. They're stable, you've got them on good therapies. I'll see you again in 3 months. A couple of weeks go by, and this patient goes to primary care. They're hypotensive, blood pressure is low. What's her blood pressure? 104/77. Not in the cardiovascular world, that's not hypotensive. But they say, you know, I see you on the ARNI. Let's stop the ARNI, and hopefully that blood pressure will come up. I'll see you in 3 months. Now nobody's gonna see this patient for a long time. A couple of weeks, 2 weeks go by, they're no longer on the ARNI, they start to get a little short of breath. They're worried, they call you up. But of course, nowadays, that phone call doesn't come to your office. It goes to some call center where they're waiting 10 minutes on hold, they finally give up, they hang up, and a couple of days later, they're admitted to the hospital. But not your hospital, an outside hospital, so you have no clue that they're actually admitted. All the meds are stopped, they get diuresed, they get discharged to a skilled nursing facility, only on a low dose of beta blocker. Luckily, there's a good doctor there, because we started them back on the ARNI, on the SGLT2 inhibitor, and now they're on good therapy. They get discharged from that skilled nursing facility, they're feeling great. They go to that pharmacy with that financial aid they had for their 2 expensive brand name drugs, it's expired, and there's no one to help them. So they don't pick it up, they're only on 1 medication for their heart failure when they should be on 4. So what happens? The whole cycle starts all over again, they get readmitted, this time sicker than before, they're now intubated, they're on inotropes, they have a much longer hospital stay. But they finally get out, and guess what? Just in time for that scheduled appointment that you had with them 3 months later. And they walk into the clinic, you walk in and say, hey, how's it going? Because you have no clue what just happened. That is the problem with episodic care models today. So we need to change our clinic day, restructure it. We need to change the episodic care model that we have. And we need to think about how do we redesign this for the future? Well, ideally, in the future, your day looks something like this. You still start the day the same way. You have your procedures in the morning. You go to the cath lab and you do your procedure, but you have some extra time built in just in case things run over. So you're not rushing to see that next patient. When you see that first patient of the day, you already know their labs are completed because it's being tracked and taken care of, and someone is making sure that happens outside of your clinic because you're monitoring them at home. The second patient of the day, they were supposed to have a follow-up in about a month. They weren't actually supposed to come in today, but because you were tracking them, you saw some signals, things weren't going right, and you brought them in instead of relying on them to come in and realize what was going on. Now, because you are only getting patients in who need to be seen, you have a little bit of free time, and instead of managing patients one at a time, you're going to work with your team of NPs, PAs, nurses that you have in your clinic, and you're going to do what we call team population management. You're actually going to look at your entire 3,000 patient population and say, who needs my help today? Who can I make some changes for outside of this clinic without having to see them? Or who do we actually need to bring in to make changes for them? Then you have a nice leisurely lunch. You don't have to grab that pizza. You can actually eat healthy and maybe lose a few pounds. We'll see. After lunch, some guidelines have changed recently for AFib. So you redesign some of your clinical pathways. You are now a clinical care designer. That's kind of your job as the MD. You're going to design some new clinical pathways, and you're going to see some new patients the afternoon, and you end your day much happier, knowing that everything you provided was high value. But how do you get to this future? That's the question. We need a new care model, a more continuous care model. Not this episodic care model where we only see them in clinic and that's all the data we have. We need to have data from the home and in the home and all the other places that the patient lives and is seen. And we also need to redesign the roles of who we are as physicians, as PAs, NPs, as nurses, even our medical assistant, and bring in new roles for health coaches and people who actually interact with the patient at home. The physician, instead of worrying about the day-to-day, really needs to think about the patient holistically, design their care, and really focus on the things they're really good at. When you have those complex patients that nobody else can handle, that's the complex decision-making a physician should be doing, and doing procedures because they're the only ones trained to do it. Meanwhile, you have your APRNs. These are the ones who can deliver that day-to-day care. They're the ones who can actually implement the care plan that's designed by the physician. And then lastly, of course, is the medical assistants who assist the rest of the team and make sure that the logistics within the clinic happen. And the health coaches make sure the logistics on the patient side happen. Make sure that the patients have success. But if you just rely on humans to do all of this, there's going to be gaps. Because how do we make sure that everyone is tasked and the appropriate things identified for a patient for each of these players to actually come in and have value? That's why you need a platform to connect all of them together and make sure that everyone is in the same loop. So for physicians, let's go into some more. What do we want them to do? Well, for home titration for heart failure or for hypertension, we want them to set up the initial plan. They know the specifics of the patient. They know what's best for this patient. Let's make sure we get them on the right meds. If things are getting out of control and the APRN can't handle it, let's escalate it up to the physician. This is the care design tool that we have within our platform. It's integrated into the EHR. We actually first identify those patients who have gaps in care or are at risk. And on the left here, you'll see that we provide that list along with all the information that the patient needs to the clinic physician to say, here's a patient who needs your help. Here's a patient whose care gap we can fill. Let's get them enrolled in one of our disease programs. We get them enrolled. Based on our algorithms, we can actually say, here's the care plan this patient needs, here's how we need to do testing, here's how we need to change your therapies, and here's how we're going to do it over time. The physician can come in and tweak it as they see fit, if they need to, and hit go. And that's when our APRNs come in. They're the ones who are going to implement the plan. They're the ones who are going to make sure that when the next medication change is needed, it's happening. They're the ones who are going to order the labs. They're the ones who are going to see if there's anything, like a small side effect the patient has, how do we address that? They're going to do the day-to-day of the operations. And how are they going to do that? Oh, it's broken to pieces here. But this is kind of our storyboard that lives within the EHR that shows them all the data. So the top here, you can see blood pressure, weights, heart rate, whatever vital signs or physiologic data they need to make decisions. Below that, on the same timeline, is things like symptoms, labs, other data that we're getting from outside sources and from outside devices. And below that is the actual medications and therapies that we're actually changing for the patient and how it relates back to all the things that are going on with them. But we don't want you to have to look at this. No one's got time to look at this data for 3,000 patients. So all of the things that are abnormal here, you can see some orange vital signs, for example, that are abnormal at the top. Those are going to be associated with some sort of alert. Our algorithms will automatically detect, is this something that we need to worry about and notify someone about? Or is this something that we don't need to worry about? We can actually directly tell the patient, keep doing what you're doing, let's continue to monitor. And if we do need to alert someone, who do we need to alert, how urgent does the alert needs to be, and let's recommend an action associated with that. Maybe you're just started on a new medication and it's lowering your blood pressure too much and you're having symptoms. Well, maybe let's make a recommendation for a different medication. So make that decision barrier a lot lower for the providers. And then, of course, is the at-home care. This is where the health coaches come in. So a lot of what we talked about already is very algorithmic, it's automated, and it's much more on the clinical side. But how do we actually affect the patients at home? health coaches are going to be crucial in helping guiding the patients in the process, how to get care, how to provide pharmacy access, how to make sure that they know when they need to get testing done. And if they have barriers to get testing, maybe they can't get to the labs, maybe they can't get to the pharmacy. Let's get medications delivered. Let's get in-home phlebotomy. Hey, maybe we can do an echo at home. Let's make all that happen so the patient is where they need to be at the right time. When we interact with the patient, the health coaches, well, we'll have some automated messaging. You can see here on the left, we work primarily through SMS. We decide to go against an app because it's often a barrier for many of our patients, especially, for example, our elderly patients. But guess what? Almost all of them text to their grandkids. So that's our approach. But our health coaches can also text the patients, and even if they can't text, they'll pick up the phone and call the patient, which almost everyone can interact with. If the patient doesn't interact over text, we'll have embedded links. We can actually do some richer experience to get symptoms or to deliver information on education, etc., and really provide a more rich experience for those patients. For those who can't, health coach is always that physical, human touch that really provides the backup needed to make sure the technology is a success. So this is kind of a summary of our platform, what we do. As I said, we start with the EHR, we integrate into it, we find those opportunities of patients who have gaps in their care, understanding the context of their total healthcare. We then service that, get enrolled in our program. We then connect with the patient at home with things like remote patient monitoring, also in-home services, really providing data the clinician needs to make decisions, also connecting with other outside sources of data, for example, their laboratory, their pharmacy. We'll do things like looking at their refills and say, maybe that primary care doctor shouldn't have actually prescribed that medication. Let's notify the cardiologist who's taking care of them using our platform, and you can be notified of things you otherwise would have had insights into. And of course, the last piece here that I've spoken about already is our health coaches, that human touch that's so important. And this allows us to then identify, really orchestrate the care goals and get patients to goal, and then even when they're at goal, making sure that we ensure success for that patient over the long term, because we know that even when we achieve our goals for therapy or diagnostics for these patients, oftentimes they fall off and we need to bring them back in. So what are the results of using a platform like this? Our first partner was ChristianaCare, the largest healthcare system in Delaware. We've been able to achieve 7% 30-day readmissions compared to about 20% readmissions nationwide, which is kind of where they were before. Our daily patient engagement, now we're not talking about just patient engagement, daily patient engagement is 85%, and that actually stands true even a year after using our platform. Similarly, we're able to reduce those patient no-shows and lost follow-up rates. Extremely low lost follow-up rates. I don't think anyone really knows what their lost follow-up rate, but it's at least 20, 30, in some cases it's estimated at being as high as 60 or 70% depending on your point of care. And of course, our Net Promoter Score, for those of you who don't know, this is how do patients feel about this? Would they recommend it to a friend of theirs? We're 88. That's huge. That's bigger than Apple, for example. And average in healthcare is only 38. So patients really love this too. In fact, we have a study coming out with our research partner Duke that shows that not only do they like what they have, they actually trust their doctor more because of the platform. And this is the clinical data. So this is looking at all 4 pillars of guideline-directed medical therapy for heart failure and comparing it to the national data with our patients on our platform. You can see every single patient was on some form of beta blocker, and we're able to get most patients actually at target therapy. Similarly for ACEs, ARBs, ARNI, and MRA, even though some of those are actually brand name. What's not on here is SGLT2 inhibitors because it wasn't looked at the CHAMP-HF registry. So we also said, let's look at where patients started in this population that we're treating and where did they get to. And we can still see across all 4 categories, we're making a huge difference. And that's why we're having those clinical outcomes in terms of reduced readmissions and sort of patient satisfaction that you see. So again, I think there's value in everything you've seen today in terms of the technology. We have to tie this technology to the human piece, to the services. You really have to have an end-to-end solution. And that's, I think, what we're trying to provide. We're trying to provide intelligent context, but also personalized automation, not just something that's generalized for the population, and providing a clinical extension arm for any of the providers, all the way from the MD down to the MA, to make sure that we're offloading them so they can practice the highest level of care that they possibly can. We've also now implemented several other programs, including population-based health programs in dyslipidemia, hypertension, more procedure-based programs for atrial fibrillation, post-MI care, and we're going also now into sort of cardiac-adjacent diabetes, chronic kidney disease, ultimately really trying to tackle the multi-disease processes, for example, under metabolic syndrome, where you have to tackle all the diseases at once and how they relate to one another. I would love to partner with anybody to make this happen for you as well. The cardiac clinic of tomorrow, it doesn't have to be tomorrow, it can actually be today. Thank you, everybody. Any questions?
I think that the first question always comes to my mind is, I like the idea of what reality and what the ideal is. I'm going to cut to the chase and come to the point, like, where is the, in terms of enough, thank you. Thank you. My question is, who's paying for this? What's the return on investment? So I think, the reason I'm starting this because almost everyone is going to look at this. I think, who's going to pay for it? How much does it cost? And what's the ROI? Yep. Now, I know there is an ROI that you can calculate, which is based on the readmission rate, and that's a whole another ballgame. So I totally understand.
Yeah. Are you talking about specifically in heart failure then?
That's the model that you're talking about. So.
Yeah, so I think in heart failure, it's actually probably easiest to answer there because there's a lot of ROI. Most ROI is probably there. So in heart failure, as an example, a lot of the monitoring that you do here is there's now new reimbursable codes, right? There's remote patient monitoring codes. Most health systems are not taking very good advantage of their chronic care management, principal care management codes. So on day one, just by providing the services, you're actually getting reimbursed as a healthcare system. And that's just from delivering that care in this way. But now there's also some new value that you can realize. So in heart failure, for example, reduced readmissions. Now depending where you are, reduced readmission, that's a cardiac bed potentially. You're diuresing a heart failure patient. The margin of value is very low. You'd rather fill up with a stent or a cabbage or some other patient who has a higher value to the hospital. And you want to keep that patient out of the hospital obviously for care reasons. So you're going to get value there too from the readmission. Then there's kind of the longer term value, right? So we have done this, for example, with one of our partners. They were able to, because we're now capturing patients earlier in their disease process, a lot of the data actually showed you it's from an advanced heart failure clinic. So these patients are actually sicker than the average, which I think makes the numbers even more believable, because if you can have that kind of numbers in an advanced heart failure clinic, then you can definitely do a general heart failure population. What it also allows the advanced heart failure clinic to do is see people earlier in their disease. And so they've been able to double their LVADs. One LVAD pays a hospital a profit of about $200,000, $250,000. You can cover it with just one LVAD. But I'll tell you that one of the programs in 2 years basically has found, I think, 7 LVADs, 2 heart transplants, and 1 LVAD that went on to transplant, and a population of 170 patients, 180 patients. So that's a huge ROI. We haven't even talked about the staffing. That I talked about, the efficiencies in staffing, the ability to scale your nurses and NPs, etc.
What's been your experience working directly with payers?
Yeah, I think it depends on the payer. So I think there's, obviously in some ways, the payers actually have more value to get out of this than the fee-for-service providers. I look at this as something that works in the fee-for-service world, but actually can build a bridge to value-based care for anybody. Whether it's a health system wants to move there, or if you want to do it with a payer, that's also very possible. I think payers, for the most part, want to see the proof points. And so I think that's where now we have the clinical data. We just presented our first clinical data last month. That's kind of the place to start, is once you show the proof point, especially with the readmission data and that sort of thing, then there's really a story you can tell. It's not too hard to sell. Any other questions? All right, well, thank you, everybody.